Morning. Welcome to the 3-Minute Read podcast. I'm John Dalton, editor of the twice-monthly newsletter of the Healing American Healthcare Coalition. Joining me again today is Ed Eicchorn, the coalition's co-founder and co-author of Healing American Healthcare, a plan to provide quality care to all while saving $1 trillion a year. Together, Ed and I have more than a century of healthcare experience, and we're still trying to figure it all out. You can find our background and contact information at the end of this podcast. We're here today to discuss the February 10th issue of the 3-Minute Read. As you can see from the contents, it begins with Johnson & Johnson applying for an emergency use authorization for their vaccine. And then the next three articles really focus on drug pricing. There's been a lot of chatter in the literature about the high cost of prescription drugs, and these three articles kind of summarize some of the issues. And then we conclude with Ed Eicchorn's monthly blog, a summary of this podcast on 3 ways to lower drug costs now. So let's begin with the J&J announcement. The first article we summarized was Johnson & Johnson applies for emergency use authorization for COVID-19 vaccine. That was reported on NPR by Dustin Jones on February 4th. So Johnson & Johnson has applied to the Food and Drug Administration for its Janssen vaccine. Some key facts about their vaccine: if the EUA is granted, J&J expects to supply 100 million doses through June. Its overall effectiveness is 66%. In the U.S. clinical trials, it was 72% effective. The most important, it's proven to be 85% effective in preventing severe forms of COVID-19, so reduced hospitalizations, reduced deaths from COVID-19. So that 85% is very important. It requires only one injection. Unlike the Moderna and Pfizer-BioNTech vaccines, the J&J vaccine requires only one injection, which reduces some of the logistical challenges, and it can be stored for at least 3 months at 36 to 46 degrees Fahrenheit, routine refrigeration. So the good news is that having a single-dose vaccine available that doesn't require cold storage should accelerate getting more Americans vaccinated. The FDA is expected to hold the first meeting of its outside advisors next week to review the application. That will be February 26th. If approval moves forward, it could be in use by mid-March. Ed, anything else on the vaccine update?
Sure. Let me add a few things, John. We are recording this on February 19th, and much of the nation has suffered from extensive snowstorms, even all the way down to Houston, Texas. And even as we are recording this, there are 12 states that have severe weather restrictions. And this is impacting the delivery of vaccines around the nation. The main hub for this, for FedEx, is actually in Memphis, Tennessee, and there's difficulty getting in and out of Memphis at this time, and they're moving to other hubs around the country to try to distribute medication. And this problem will continue for a while because much of the nation is ready to provide the injections, and it's become a supply and demand issue because the supply is certainly not reaching the demand, but that will be corrected over time. In fact, last Thursday, President Biden held his first town meeting in Wisconsin, and during his response to the questions from the audience, he said that he hopes to have 600 million doses available in the June-July timeframe, so that anyone who wants a vaccination will be able to get one. He's used the Defense Act to ask Pfizer and Moderna to produce more vaccine, and he hopes that J&J will be approved by the FDA at the end of February or the beginning of March. That will certainly continue to add to the supply. So I think the future for vaccination is certainly looking up. Without the snowstorm that we've had around the country over the last week, the United States has been averaging about 1.6 to 1.7 million injections a day, and it's anticipated with the increased availability of supply that we've just talked about, it could go up to about 3 million doses a day, which would certainly improve our nation's ability to move forward. As of now, about on average, 12% of Americans have received their first injection, and about 5% have received the second injection. And that's kind of where we stand at this point, John.
Yeah, and here in New Jersey, although yesterday was disruptive to many of the vaccination sites, it was reported that 1.5 million doses have been administered here in the state, and 437,000 of those were the second doses. So 5% of New Jersey's population now has received both doses of the vaccine. and about 12% have received at least one dose. So that's all good news on the vaccine front. Now let's see what else is happening in drug pricing. The next article is entitled, "Here's How Much More the U.S. Spends on Prescription Drugs." And it's written by Christina Fiore, Director of Enterprise and Investigative Reporting for MedPage, and it appeared on January 28, 2021. A recent RAND Corporation analysis took a look at prescription drug pricing throughout the OECD, the Organization for Economic Cooperation and Development, which is the major developed countries in the world. It found that we are paying about 2.5 times as much for drugs in the US as do 32 other countries that they looked at. The total drug spending in 2018, the year they looked at, was $795 billion, so approaching almost $1 trillion throughout the OECD. And here's what they found. For brand name drugs, the US is paying almost 3.5 times more than other OECD countries. But we are paying 16% less for generics. That's the good news. And here in the US, generics account for 84% of our volume. So to me, that suggests that we've all gotten the message that brand name drugs are expensive. Those of us who have Medicare Part D or other Medicare plans have been working with our physicians to make sure that when there's a generic available, we get the generic rather than the brand name drug. In other OECD countries, because drugs are much more affordable, generics only account for 35% of the volume. Here in the US, the brand name drugs are only 11% of total volume, but they account for 82% of total spending. Now, among the G7 countries, the major Western democracies, the UK, France, and Italy have the lowest prescription drug prices. A former board member, colleague of mine, used to be VP of Government Relations for one of the major pharmaceutical companies, and he always used to bemoan having to go to the UK and France and negotiate drug prices with the governments there because he always felt that they were squeezing them too hard. But they're getting a much better deal than we are here in the US. So the conclusion from RAND, Andrew Mulcahy, who was their chief researcher, commented, quote, "Many of the most expensive medications are the biologic treatments that we often see advertised on TV." And he expressed hope that competition from biosimilars will begin to drive down prices and spending for biologics. And as most of you know, you can hardly spend an hour watching TV without having 3 or 4 high-priced brand name drugs being touted. The next article is entitled, "States Move Ahead with Canada Drug Importation While Awaiting Signal from Biden." And that was written by Phil Galewitz on the Kaiser Health News, January 29. In 2003, America enacted the Canadian Drug Importation Law. It required that the HHS secretary certify that such drugs could be imported safely and effectively, and former HHS Secretary Alex Azar certified that last September. That's 17 years later. Now, why are we looking at Canada? Canada limits how much drug makers can charge for medicines. So Azar acted in September. In November, the Pharmaceutical Research and Manufacturing Association filed suit in DC federal court to stop the drug purchasing initiatives. Why? Because we're paying higher prices here in the US. Now, Florida, Colorado, and several New England states, Maine, New Hampshire, and Vermont, are moving ahead with efforts to import prescription drugs from Canada. Canadians are willing to export drugs so long as they have enough to satisfy their own consumers' and patients' demands. Anything excess would be available for export to the US. And we already read stories of folks in Washington State, New Hampshire, Vermont, etc., crossing the border to buy prescription drugs in Canada and then coming back across the border with their lower priced drugs. Now, some high priced drugs in the law, such as insulin and other injectables, are excluded from importation. So even though the law was passed in 2003, it did exclude certain drugs from being eligible for import. Experts, on the other hand, are questioning whether the savings could be significant because of the expense of setting up and running an importation program, whereas each state would set up their own program for patients and consumers in their state, and that could be a fairly expensive ramp up, not dissimilar from what happened as various states set up their own healthcare insurance exchanges under the Affordable Care Act. The third article was entitled, "Seniors Face Crushing Drug Costs as Congress Stalls on Capping Medicare Out-of-Pocket Costs." This is also from Kaiser Health News on January 4th, written by Harris Meyer. Now, except for very low-income beneficiaries, Medicare Part D drug plans don't cap the patient's co-insurance costs once they hit $6,550 in total drug spending. So they'll pay 5% of anything in excess. Now, since many of the high-cost cancer drugs now are available in oral form from pharmacies, some of our seniors now face crushing costs if they're fighting cancer. The article indicated that from 2010 through 2018, the average prices for 54 orally administered cancer drugs increased by 40%. And the average for the 54 for 1 year's treatment would be $167,904. So for a Medicare beneficiary paying a 5% coinsurance on top of that, that would amount to something like $8,400 a year. So the high prices and the coverage gaps force many of the patients to rely on the financial assistance programs offered by drug companies and their foundations. However, applying for such assistance is a very complex process and requires filling out forms and reapplying on an annual basis. So it's available, but difficult to access. And surprisingly, with cancer centers throughout the U.S., including many major brand names, only 5% of U.S. cancer centers have an expert on staff who can help patients who are facing problems with paying for their care and paying for these orally administered drugs. So it's little wonder that nearly 70% of seniors want Congress to pass an annual limit on out-of-pocket drug spending for Medicare beneficiaries. But the holdup is that Congress can't figure out a way to finance that. They'd like to push it back onto the drug companies. And of course, pharma is probably one of the most active and effective lobbying groups in DC, right alongside America's health insurance plans, who represent the insurers in DC. With that as a setting, Ed Eicchorn's monthly blog talked about drug pricing. Ed, why don't you walk us through some of the ways that the U.S. might be able to help reduce drug costs now?
Sure, I'd be happy to do that, John. My blog was entitled, America Needs Lower Drug Prices Now. Here are 3 ways to do it. And what I was looking at was the challenge that we have when compared with the OECD nations. Almost all of them negotiate drug prices on a national basis, as John alluded to in Canada. But that's a very tall order in the United States. Pharmaceutical industry market in the United States is about $500 billion a year, and they employ over 880 lobbyists on a regular basis. Now, if you think about that for a moment, there are 435 congressmen and congresswomen in the House of Representatives and 100 people in the Senate. That would be a total of 535 elected officials in Congress. But the pharmaceutical industry employs an additional 300 lobbyists above the total number of people who we've elected to Congress. And, you know, they are a real force to bring their representation to Congress when there is a threat to the pharmaceutical industry. And certainly national negotiation would be a big threat to them. There are 3 ways, though, that I believe Congress could act before approaching a national negotiation bill, which would be very difficult to pass given the lobbying pressure that Congress would receive. The first of these is in hospital drug pricing. Approximately 40% of the more expensive drugs are provided to patients in the hospital setting. And these prices are not regulated. And there's been a lot written about hospital markup of drug prices. The most significant work, I believe, was done by Stephen Brill in his book that was entitled America's Bitter Pill. He found out that, for example, a Tylenol pill distributed in a hospital actually costs the patient more than the bottle of Tylenol costs on a wholesale basis. And there was a study done by the McCann Group in Philadelphia where they found that in some cases, hospital markup of drugs was as high as 487%. So the hospital markup of drugs is certainly an area that could be controlled. And we would recommend that hospital drug markup be approximately 10% to reflect the cost of inventory and the delivery of the drug to the bedside. The second area is on orphan drugs. Orphan drug legislation that was passed in 1983 is extremely important because it encourages pharmaceutical companies to develop medications for diseases that affect 200,000 or less people. And more than 300 drugs have been produced that actually extend or save lives. However, the price of orphan drugs since 1983 has gone up by a factor of 64 times. In 1983, the actual cost of pharmaceuticals that were orphan drugs was around $1,500. And today, it's well over $100,000. In fact, the 7 highest cost drugs in the United States right now are hepatitis C drugs that were developed under the orphan drug rule. And the average cost of those drugs is between $50,000 and $80,000 a month. And treatment can be anywhere from 8 to 20 weeks for that. So that area of expense should be controlled. The other aspect of this that is troubling is a drug that has been on the market for a number of years can actually be found to have an orphan drug use. That means the price will go up. There is a drug that's used for arthritic care, but also was recently found that it would deal with infant symptoms that could be fatal. These infant symptoms are such that it requires this drug. Well, anyway, the treatment using this drug that used to be $20 a vial can cost $500,000. So it's good to have these treatments, but we ought to have a way to control the price so that it's not exorbitant, especially in drugs that have been on the market for a long time. I think pharmaceutical companies should be able to double or triple those prices, but they shouldn't be able to multiply them by a factor of 1,000 in order to establish a new price. The last thing was covered in part of John's presentation, and that is allowing drug importation. It really makes sense to promote international ordering of drugs to lower costs for Americans. But as John indicated, it took 17 years for Health and Human Services to certify imports from Canada as being safe and effective. For a long time, pharmaceutical industry said that importing drugs may not be safe. Well, if the drugs are made by the pharmaceutical companies in the United States and exported, or made in a foreign country under their quality control systems, it should be safe to bring a drug back into the United States. So with these 3 things, I think we could have an impact on drug costs in the United States much before we can get to a national negotiation for drug pricing.
It took 17 years to get Canada approved. Imagine the hurdles we'd have to go through if we wanted to import drugs from the UK or France or Belgium or Sweden, all of whom have plants operated by American pharmaceutical companies. To me, it just seems incredible that it took 17 years just to get Canada, our neighbor to the north, approved for importation of certain drugs, so long as they're safe and effective and efficacious. I like Ed's recommendation of Stephen Brill's book, quote, A Bitter Pill, close quotes. It's one of the best books in terms of insights into the complexity and some of the hurdles that we face in delivering healthcare here in the U.S. as compared with the other OECD member nations, all of whom have universal healthcare systems. So that said, we're interested in what you're thinking. We'd like you to go to our website, www.healingamericanhealthcare.org, and take a brief survey. We've already received responses from a number of folks. We're interested in your thoughts if you haven't completed it yet. And in future podcasts, we'll share feedback with our listeners on issues that include universal health care, which is not, by the way, Medicare for all. It's Medicare for all. It's just one approach to universal health care. And we'll be talking about the Eicchorn Hutchinson All Care Plan, part of which you just heard from Ed in terms of the 3 steps for controlling drug costs now. So if there are issues of particular interest that you would like to see covered, please feel free to contact us, and here's our contact information. If you'd like to join our mailing list, just text HEAL Healthcare to 22828 to get started. And we look forward to seeing you again. Continue to wash your hands, watch your distance, and wear a mask. Thanks.